We have extremely effective treatments for asthma, but by contrast, treatments for COPD are very ineffective. We do have good long-acting bronchodilators which are helpful to patients, but no drugs that exist are able to reduce the relentless progression of the disease, are able to reduce mortality, or are very good at preventing exacerbations. And this because we don't have any treatments that suppress the underlying inflammatory process. So my research has been focused on trying to understand the underlying mechanisms of COPD in order to identify new therapeutic targets for future therapies. One of the things that is very striking is the difference in response to steroid therapy between asthma and COPD. And COPD patients have a very poor response for steroid treatment unless they happen to have associated asthma, so-called asthma-COPD overlap. So most patients with COPD have no response to steroids, and we've been looking at why this should be, and we found that the inflammation in COPD is steroid resistant, and we're beginning to understand the molecular mechanisms of this steroid resistance, which include decreased function of a nuclear enzyme called histone deacetylase 2, which is necessary for switching off inflammatory genes and is the way that steroids are so effective in asthma. And the reason that HDAC2 is reduced in COPD seems to be a consequence of the high levels of oxidative stress in the lung, which lead to the activation of a signaling pathway that involves PI3 kinase delta, leading to a reduction in HDAC2. So the possibility is that in the future we may be able to reverse this resistance by blocking this steroid resistance pathway. In fact, we already have drugs that are able to do this, such as theophylline, in low doses, targets PI3 kinase delta and is able to restore HDAC2 levels in COPD cells. This has led us to undertake 2 large trials of low-dose theophylline in COPD patients, and these trials are currently underway. We've also found other drugs can reverse steroid resistance, including nortriptyline, which is an old antidepressant, and macrolide antibiotics, as well as new drugs such as selective PI3 kinase delta inhibitors that are currently undergoing clinical trial. So this is an interesting new potential approach for treating COPD. But another area of interest to us is to understand the progression of COPD, and particularly emphysema, which we believe to be an acceleration of the normal aging process. And we're now beginning to understand the molecular pathways of accelerated aging and have shown that these are activated in COPD, and again have highlighted several molecules that could be targeted to reverse the progression of the disease. One of the features in aging lung is that there are reduced levels of sirtuins, particularly sirtuin 1, which is an important anti-aging molecule. And we believe that there are drugs that can target the pathway that reduces sirtuin 1 in COPD and therefore reduce the acceleration of the aging process and therefore the progression of the disease. There are many other targets for new drugs in COPD, including several kinases such as P38 MAP kinase and JAK kinase that are known to be activated in COPD, and inhibitors of these drugs are now developed and are in clinical trial in COPD. So I'm hopeful that in the next few years we will have new treatments for COPD that will prevent its progression, mortality, much more effectively prevent exacerbations, and hopefully will improve the symptoms and the quality of life of these patients.